Well, my philosophy of patient care is that there is always hope. Regardless of the circumstances, regardless of the disease, how serious the illness is, there's always hope that the next day may bring something good your way. We try to work with our patients as individuals. We know that cancers behave differently. Patients are all different. I don't believe in giving statistics that a certain life expectancy is appropriate for a particular stage of disease. I think each person is going to react differently to treatment, and so I think that it's a hopeful course of action that we try to take and make people know that we're going to be there throughout the illness. Hopefully it will end up well, but if not, we will do our very best to keep people comfortable and give them a quality life as long as possible. When I got to medical school, I really came to love the oncology patients because I found that treating patients with cancer was more of a group effort. It involved not only the patient and the physician, but it involved the patient's family, friends, church members, plus the nursing staff, all of the personnel. It was like a community effort, and I always liked that better than certain other fields where there might not be quite that interaction with so many people. Well, as I said before, I grew up in Meridian and graduated from Meridian High School. There were two colleges that I had the opportunity to attend and decided on Millsaps College. From Millsaps College, I was accepted to University Medical Center here in Jackson and trained at the medical center, did my internal medicine residency under Dr. Harper Helms, and then my oncology fellowship under Dr. Tate Thigpen and Dr. Joe Files. It's been a very rewarding experience, and University Medical Center trains me very well, I believe. At this time, the most important things that I see in oncology are the personal therapies that are being used. You can now profile a patient's cancer and determine exactly what type of treatments may be available that would be beneficial, as opposed to just giving a generic treatment that may be prescribed for all patients but may not be specific for that particular patient. So I think in molecular profiling we've made a lot of advances. The types of cancers that I think we're seeing the most progress in, as far as I'm concerned, are the colorectal cancers and the renal cell cancers, genitourinary cancers, and those are particular cancers that I'm very interested in. Molecular profiling is a procedure in which the tissues are taken by the pathologist, and then they're sent to a laboratory, and you can get an actual fingerprint, so to speak, or a signature of the cancer that gives you information as to what the risk of recurrence of a cancer is. There are certain companies that perform those studies for us, and it can tell us if we need to give adjuvant treatment to women who have early stage breast cancer or not. Not all women need chemotherapy after their surgery, and this is one way to distinguish those who are at low risk versus those that may be at intermediate or high risk that need chemotherapy or hormonal therapy for their treatment. There are other types of cancers that we know if there's a mutation in a particular enzyme that cancer won't respond as well to certain drugs. Colon cancer is a particular cancer that behaves in that manner. There's a pathway involving KRAS, which is just a particular genetic pathway or signaling pathway. And if there's a mutation in that pathway, then certain drugs won't be effective, and so you know not to use those drugs and put the patient at risk of having complications of those drugs when they won't work in the first place. I believe that my mission is to do all that I can to bring glory to God, to bring comfort and relieve suffering to my patients.